morning, everybody. Welcome to our virtual medical grand rounds. As many of you know, we have a long history in the Department of Medicine celebrating our senior physicians that have really set the tone within our department. And so to that end, I'm happy to introduce Dr. Van Santent to introduce our Wensel Sherbaniuk lectureship and our speaker today. So with that, Sandra, I'll hand it over to you.
Norman, thank you very much. I hope everybody can hear me well. So it's a great honor to introduce Professor Fergus Shanahan, who received this year the Wensel Sherbaniuk Lectureship Award. On this picture, you see Dr. Wensel on the left and Dr. Sherbaniuk on the right. Sadly, Ron passed away this year, but Dr. Sherbaniuk is alive and kicking, and he is attending the lecture. Dick, welcome. The lectureship really is to honor Dr. Wensel and Sherbaniuk. They really were the founding fathers of GI, but especially also academic GI in the Edmonton zone. Soon, when the two of them were basically starting gastroenterology in the Edmonton zone, they really realized that in order to bring it up to an academic level, we needed to hire academic gastroenterologists. As money was also scarce at that time, the two of them together from their own money as private physicians actually created a position for an academic, and this became Dr. Fred Weinstein, who went on to a very illustrious career, both nationally and internationally. So you see on this slide the plaque that is outside classroom, where the previous 15 awardees are listed, and Dr. Shanahan is absolutely very deserving to be this year's lecturer. Fergus is currently the Emeritus professor, one of the Emeritus professor at Cork University College in Cork University. He's been absolutely an international star in GI. There is a little bit of a Canadian connection, as he did some training at McMaster University, then went on to the Mass General in Boston and worked for a while in Los Angeles before he went back to his home, Cork in Ireland. At the moment, he has close to 600 publications, especially in IBD, but also covering the entire field of gastroenterology. And I can say personally, I always attended Fergus's presentations at the various meetings, at the various venues, and he definitely influenced my thinking about my research quite significantly. So he's received numerous awards nationally and internationally from medical societies and organizations, and has been a great contributor to the field. He is also very interested in the medical humanities and has written about it as well, and has received some very prestigious awards about this. So today he's going to lecture us about The Language of Illness, a book that he recently published. And I'm actually in the middle of reading it, and it's a great read. I can highly recommend it. I was lucky to spend 6 weeks with Fergus last year. So he is one of the founding fathers, but was also the founding director of APC Microbiome Ireland, which is a unique institution that he created in Cork. And it brought together medicine, medical microbiology, and food sciences, all of which were and are very strong in Cork. And that institute really is one of the leading institutes in the world on microbiome and probiotic research. Absolutely a dynamite institution. Very, very impressive. So Fergus, you are very deserving. You really deserve this award, and it is great to have you with us today, and we look forward to your lecture, The Language of Illness.
Thank you, Sander, and thank you to the organizers and everyone involved in giving me this award, and also helping us do this lecture from thousands of miles apart. I was asked to give 3 possible topics for this talk. And I'm usually asked to speak on the microbiome, occasionally on inflammatory bowel disease. And I've never given this talk in any formal sense anywhere before. So I was surprised when this was the selected talk. But nonetheless, I actually think it's quite appropriate given the nature of these two great Canadians that we're here to honor. This is a wonderful honor for me to do, but we are celebrating the contributions of the founders and these two great Canadians who had the wisdom to set up academic gastroenterology at a time when academia was probably not particularly popular. What followed is quite remarkable. I have some connection with Edmonton, even though I've never been there physically. And Canada has been very good to me. It trained me for part of my time, my training. And I've been back and forth to Canada many times with great friends in academia in all of the cities in Canada. The man in the center here, in between the two founders, Fred Weinstein, was at UCLA when I went there. And he was, of course, their first recruit and the first program director for gastroenterology in Edmonton. And by the time he moved to UCLA, I had just arrived and was the beneficiary of the wisdom of Doctors Wensel and Sherbaniuk indirectly. Now, I've had an opportunity to see a video made some years ago about the early years of academic gastroenterology in Edmonton. And I was struck by this remarkable statement from the first fellow in gastroenterology under those two gentlemen and Fred Weinstein. And this was Dr. Robert Bailey, who went on to have, of course, a distinguished career. And Bob Bailey said, "What did I learn from those guys? I learned how to talk to people, listening." Now that might seem to be somewhat self-evident or perhaps even banal to some people in an era where we've got fabulous technology and endoscopes for everything. But actually, that's probably the most profound statement in the entire video. And that is a justifiable contribution to medicine from anyone to teach someone how to speak to people and how to listen to people. And if I had to single out one thing in life that has served me well, it is, if not an ability to speak, at least the wisdom to know that it is important to learn how to speak to people, to learn how to express oneself, speaking and in writing, and particularly to learn how to listen. So words matter. Words matter a great deal in everything we do, in all of our exchanges. And the medical profession is perhaps not sufficiently aware of this. I'd like to comment during the course of this lecture on the distancing effect of medical language and how it can either connect or separate doctor from patient. I'd also like to address how bad language, bad medical language, occasionally becomes bad medicine. And I'll give some examples of that. And although I am a clinician first, I'm a medical scientist second, I have observed numerous occasions when clinician scientists can allow words to corrupt their logic. And one actually sees examples of that in public health as well. Finally, because we are physicians and because so many insights have arisen when doctors or nurses have become sick and then recorded their experience, it doesn't always make for a pretty picture. And although we think we know how to behave with the ill and we're trained to behave with the ill, and we think we know how we might react if a friend or loved one becomes ill, why is it then so awkward? And why is it such an epiphany for doctors who find out, albeit too late, and only when they become ill, that they hadn't actually been communicating very effectively? And when the shoe's on the other foot, when they are actually the ones who are ill, they finally realize some of the flaws in our language. I'd like to address that at the end of this lecture. And in the course of that video I mentioned on the shoulders of giants, there's a little cameo appearance of Fred Weinstein in the early days, a training video where he puts the emphasis on the words we use and how we ask questions, not just the number of questions, the type of question, but how actually those questions are phrased. And I was the beneficiary of many conversations with Fred when I was in Los Angeles, who told me how to take a history I thought I knew, but I didn't really know until I met him. He was the one also told me there's no such thing as a bad historian. We should never present a patient as being a bad historian. That's actually a reflection on ourselves. There are only bad history takers, no bad historians, because the history is always informative to a careful listener, as Fred was. The history is always informative. There is no such thing as chit-chat or small talk. All talk is informative. And in fact, use of that term, that derogatory term, bad historian, blaming the patient, actually is a rather dangerous thing to do, because I've seen numerous examples where house staff or residents or naive doctors actually miss cognitive impairment, delirium, which is reversible, or occasional episodes of incipient hepatic encephalopathy, which they miss by using that term bad historian. And Fred also told me how to take questions. Now, in my field, I deal with inflammatory bowel disease. And this young patient is actually a woman, and women are particularly susceptible, if they've Crohn's disease, to cigarette smoke. So it's not dose related. The number of cigarettes is not absolutely critical in the case of Crohn's disease. It's the presence of smoking of any nature, which is important in Crohn's disease. So the question becomes very important. And I learned early on, if you ask the question, are you a smoker? You might well elicit the response, no. If you change the nature of the question, as Fred often challenged me to do you smoke? Now you get a response, well, I smoke the odd one, but I wouldn't consider myself a smoker. So whether you use the noun or the verb is absolutely critical in certain situations in eliciting the response that you need to hear. Now, in actual fact, politicians have known this for a long time. And in fact, the Republican Party, the Trump administration, when they wanted to increase enrollment of Republican voters during the last election, they actually used this in reverse. They knew that it was important to ask either, are you a voter or will you vote? Nobody wanted to be known as not being a voter. So they used that twist on language to suit themselves. Now, of course, when I moved to Ireland, I learned something else. This is English as spoken in Ireland. If you ask an Irish person, will you take the tablets? If they say, I will, they're the salt of the earth. That's the single positive. That's an affirmative. They will take the tablets. In fact, we have a very high adherence rate to medication from our patients if that's the response they give you. You can trust them. However, if in Ireland they say after you ask, will you take the tablets? I will, yeah. Now that's the double positive. That's actually a negative in Ireland. And you can be absolutely certain there's very little chance that they're going to comply with the medication. Now the Irish actually hate to say no. So the negative is even more informative in Ireland and far more colorful. And this usually arises when the spouse comes in because she doesn't trust himself to give the proper history to the doctor. So she'll come in and, quote, sort things out. But the Irish hate to say no. In fact, there is no word for that in Ireland, in Irish, in Gaelic, really. So here's the single negative. He don't know, doctor. But we have a double negative. He don't know nothing, doctor. And then, of course, if you get the triple negative, he don't know nothing but feck all, doctor, which is far more colorful. And that's the kind of definitive negative in Ireland. But then we have a thing called the quadruple negative. You don't know no one else, don't want nothing done, do you, doctor? That's actually said in a kind of a affirmative statement, and you need to be clear on the way they ask it. That's the quadruple negative from an Irish person. So listening, words have tremendous power, and in the non-medical world, people know that. Some of you may remember or seeing numerous versions of this little video, but it's on YouTube and it's set in Glasgow. There have been a number of variants on it, but it shows the power of words. There's a blind man on the steps of this institution, and he has a little box saying, "I'm blind, please help." And the odd person throws a coin in. But then a woman passes by, looks at his sign, and changes it. And suddenly he's got lots of donations. This is the power of words. It's a beautiful day, and I can't see it. Far more emotive, far more powerful. And of course, the world of marketing and the commercial world have known this for a long time. Why is it that so many doctors don't realize the therapeutic power of their words, or the opposite? Why is it that so many healthcare administrations don't realize the power of words? And why is it that so many public health messaging doesn't take into account the importance of words? Consider this. We had a referendum in Britain not too long ago when David Cameron, the Prime Minister of the day, wanted to use this as the question, a yes or no answer. But he wasn't allowed to do that. The referendum commission insisted that actually the question had to be this, because they knew the significance of the words and how that can actually influence people's choice and the way in which they'll react in the polling booth. If this is true in politics, it's surely true in medicine as well. And we've seen actually in the recent pandemic that the pandemic is not just a public health emergency or an economic emergency or even a leadership emergency. It's actually a communications emergency and crisis. And as WHO said, we're not just fighting an epidemic, we're fighting an infodemic, in reference to whether people could trust an avalanche of information, much of which had to be properly interpreted, but much of which was inaccurate. And although the social media was blamed for a lot of this because of its multiplier effect and the accelerating effect by which misinformation can circle the world, in actual fact, there's a blurring of distinction between traditional media and even scientific media with the social media, and the latter two actually now crave publicity by social media. So long before the COVID pandemic, there were increasing challenges to the patient-doctor relationship. Since the first days of the training of Dr. Wensel and Dr. Sherbaniuk, medicine, the doctor-patient relationship, which is the cornerstone of medicine, has actually been under threat, or at least changing. And some of the elements that have made it change are technology itself, big data, artificial intelligence, decision trees, guidelines, super specialization, and everything about evidence-based medicine. But the greatest threat to the doctor-patient relationship is actually time. Almost every advance in medicine that I can think of in the last 5 or 6 decades has actually shortened the amount of time a doctor spends with a patient. And why should language interfere with this? Language should not contribute to the inefficiency of that interaction. We need to be speaking the same language. Now, of course, technology could actually change things in a different way. This is a statement from last week's New England Journal of Medicine, where a young doctor was commenting on the need for virtual technology in today's COVID crisis. And she says, "I'm not anti-technology, I'm just pro-presence. Presence being that deep engagement when two humans have eye-eye contact in the traditional doctor-patient exchange." And she laments the loss of nonverbal communication, which has been a casualty of COVID, touching, the physical exam, and the rituals that go along with the physical exam and the traditional doctor-patient relationship. But then she wonders, are there actually some advantages? Could this be, in fact, the first technology that will actually restore some of the lost time? And which would you rather be? Virtual doc on the left with some degree of eye contact, or digital doc on the right, where the doctor is just looking at the computer screen and not even observing the patient? And there are some opportunities now that we should realize. It's an invitation into the patient's space, a time to focus on the patient without the PPE, and a time of convenience for the patient, less waiting. and maybe an opportunity to reverse many of the asymmetries of the traditional doctor-patient relationship. It wouldn't take a genius to know, looking at this drawing, for whom this exchange is routine and for whom the exchange is crisis. Doctors frequently forget that when a patient arrives in, it's absolute crisis for them if it's a significant illness, but routine for us. That alone is an obstacle, quite apart from the time that's involved. But language, I argue in my book, should not be an additional obstacle. The patient is learning illness words, illness being the lived experience with disease, whereas the doctor speaks disease words fluently, which is the objective evidence of something being wrong. These are the illness words I'm referring to. You don't see these mentioned anymore in textbooks of medicine. How many students actually use these terms? How many mentors actually use these words that are actually important for patients? And I would argue that the language of medicine, the language of disease, is full of pomposity, full of obfuscation. For example, when we know the cause of something, we say, the cause of your cough is smoking. The cause of your ulcer is Helicobacter. But when we don't know the cause, we use big words like iatrogenic or essential or idiopathic, or we use the word etiology instead of cause. And medicine is full of imprecision and misnomers and offensive terms and stigmatizing terms, most of which is unnecessary. 10,000. That's the number of words a first-year medical student has been calculated to learn in the first year of their medical training. They have to learn a new language. In fact, it gets up to over 50,000 by the time they're finished their training, depending on a specialty they might do. Now, just to put that in context, the average graduate student in German or French or European languages might acquire a vocabulary of about 6,000 at most. So most of these words are 19th century legacies. Why on earth should we have a word like pruritus, which is usually misspelled, for itch? And what's wrong with a runny nose? Why do we have to have a term like rhinorrhea? Most of these words are absolutely unnecessary and an unnecessary obstacle at a time when we've less time to speak with our patients and we seem to be speaking a different language. And many patients say that in their memoirs. I've read hundreds of illness memoirs where patients will say, I seem to be speaking a different language. And very well educated patients will frequently say, I couldn't bring myself to tell the doctor the full story. And they find the words are like blows. And Molly Bloom said in our famous soliloquy in Ulysses, James Joyce's Ulysses, where did those old fellas get their words from? This is when she went to visit her gynecologist. I wouldn't trust him too far because of the big words he's using. She was brave enough to notice some of the nonsense of the words. And some of you will remember the screenplay and play Wit by Margaret Edson, in which the doctor is referring to this unfortunate woman's stage 4 ovarian cancer, using words like insidious. And before he gets the sentence out, this woman calls him on it and says, she explains to him what the word insidious actually means. But she's eventually defeated and ends up saying, when she looks to the audience, my only defense is the acquisition of a vocabulary. They anatomize me with their words. And this is remarkable because only a few years ago, Barack Obama, former president of the United States, launched what we call the Precision in Medicine Initiative. And many medical schools, including perhaps your own, but certainly many medical schools around the world, have precision medicine initiatives. In other words, fine-tuning of diagnosis, subsets of patients, refinement of the diagnosis with molecular-based everything. Now, if we aspire to an era of precision medicine, the minimum we need is precise language. And look at these hangover terms that we still have. There are hundreds of them that I found. I've just listed 4 or 5 here on this slide. This is imprecise language. Pernicious anemia, no longer pernicious. Biliary colic was never a colic. And it's remarkable in my own field how many trained gastroenterologists don't seem to actually realize in their consciousness that ulcerative colitis actually seldom ulcerates. You only see that when it becomes fulminant or very severe. Whereas Crohn's disease, where you have to make a differential diagnosis, is actually the form of IBD that does ulcerate. And there are numerous other imprecisions in our language. You'll see this every day. The vital signs are stable. Well, they're not stable if you only measure them once. And how often do we see that the nervous system is grossly intact when in actual fact it wasn't measured or examined? Numerous imprecisions that we use that we really must stop using, because some of our patients, many of our patients, pick up on it. And of course, much of our language is stigmatizing. You're familiar with the stigmatizing language used for substance use. We use words like they're clean, they're an abuser. Awful language. If we expect patients to come back, they won't come back if we actually use stigmatizing language. And 20% of people who suffer from being overweight or have obesity will say that they feel stigmatized by their doctor and are reluctant to come back to the clinic. I want to move on from the distancing effect of words and bad language in medicine now to how words can turn people into patients. Consider this article just recently in the New York Times. And it describes a distressed woman who'd noticed shedding of hair on a hairbrush. This is an extremely common situation. But the language transmuted hair shedding to balding and baldness, which of course it's not, and then all the way to alopecia. And quickly social media and other forms of traditional media picked up on this and were transmuting the language also. And then you had well-known experts, self-appointed experts calling in, offering various remedies for these poor, unfortunate patients. Where in actual fact, this is well known, has been known for centuries, and never progresses to baldness, is associated with all forms of severe physical and psychological illness, is fully reversible, and only needed reassurance. So what's in a name? Of course, it gives a sense of control and it demystifies illness for patients. But there's great risk with stigma, exploitation, and even harm. And there are disastrous lessons from the danger of labels that we've used throughout time. Dr. Sherbaniuk would have remembered that there was a time not long before he went into medicine that this was a condition that used to be seen by older clinicians on X-ray who thought that the thymus was abnormally enlarged and was associated with sudden death, and they called it status thymolymphaticus, and patients were irradiated for this, and they would have seen people present in later decades with thyroid cancer from the inappropriate irradiation. And as this doctor commented, most of the mistakes were actually because people didn't know what normal was. Now, normal cannot be the same as healthy. WHO have tried to define this, and their definition of health has actually been reduced to the absurd on numerous occasions. But normal cannot be the same as healthy. Because in Victorian times, we all had Helicobacter in our stomach, but one wouldn't have called that healthy. It was normal because we all had it. And healthy can't really be the absence of disease, because many of us are actually harboring silent risk factors for either colon cancer or cardiovascular disease. And normal also can't really be average or typical if most of us are either overweight or have a component of obesity. And it can't really be the ideal or desirable because that really only applies to the minority of human bodies, and it's a moving target in any event. So whatever definition we come up with, I think we're all a little bit abnormal and a little bit normal, and we need to tolerate imperfection and recognize variability as a biologic advantage. It's simply a part of being human. And Richard Smith was particularly concerned with the slippery nature of disease and non-disease and the potential for people to be exploited. He was the editor of the BMJ at the time he conducted this survey, and he defined non-disease as I've listed there, a problem defined as a medical condition, but which may have a better outcome if not defined that way. Examples that arose during this survey were aging, patently normal, to the trivial boredom, unhappiness, or cellulite, to the quite disturbing loneliness. Now, no one disputes that these are important conditions and they're associated with some considerable suffering. But there's one essential thing to say about non-diseases. They're incurable with medical treatment. And many people in your audience there will remember seeing on television when they were children the exploitation of normal people and the creation of non-diseases. Horlicks, for example, which is a form of food, was advertised as being something that would protect against night starvation. They created an illness, a problem, a disease, which didn't actually exist to sell the Horlicks. And what about this one? The use of a medical term for something that's actually normal, malodorous breath, and sales of Listerine skyrocketed because of the use of a medical term for something that's really actually quite normal and is solved by just brushing the tongue, because it's bacteria in the tongue that create the odor. So Listerine did not so much make a mouthwash as it created halitosis and changed the way people looked at all these things. So words count in the way in which people are manipulated. And there have been numerous publications about the over-medicalization, which is one of the great problems we have in modern medicine, the over-medicalization of society from corporate-sponsored disease mongering. And I've listed some of those conditions that I would regard as non-diseases are certainly not proven as significant diseases. But it's more serious than that. What about when bad language actually becomes dangerous or bad medicine? And now I take an example from the field of gastroenterology, and I justify it because this is irritable bowel syndrome. So this is a common condition. This affects, in surveys, in every country, somewhere in the range of 7 to 14% of the population. So this is an important condition. And about 1/3 of these patients are labeled as having constipation predominant IBS, or IBS-C in the pie chart, or diarrhea predominant IBS. And about 1/3 have a mixed pattern where the patient will sometimes tell you they can have both types, diarrhea and diarrhea, in the same day. And it's been known that these subsets are not real. They actually interchange with each other if you follow patients over time. Now consider a patient who comes in to see the doctor and says, I have IBS. I have irritable bowel syndrome. I'm always in the toilet. I can't get off the toilet bowl. The doctor interprets that to be IBS-D, diarrhea predominant, because patient can't get off the toilet bowl. That's increased bowel frequency, and that's often transmuted into diarrhea predominant IBS. And the prescription is an antidiarrheal. Same patient decides to get a second opinion and goes to a different doctor. I have IBS. I'm always in the toilet, continually straining at stool. Now the doctor interprets this as irritable bowel syndrome constipation predominant and prescribes a laxative instead of the antidiarrheal that was prescribed the day before. Now what's actually happening here is the doctor isn't listening carefully. What this patient has, and what all these patients have, is a visceral hypersensitivity, and what they're actually complaining now with this symptom is a sense of incomplete evacuation of stool. That's what it is. So both statements from the patient are correct. It's neither constipation nor diarrhea. It's a sense of incomplete evacuation. Now you might think that's just an academic nuance, but consider what happened some years ago when a drug company produced a medication that was actually intended for young women with so-called diarrhea predominant IBS. Loose language, loose diagnosis, and wrong treatment emerged. And some of these patients ended up with fecal impaction because they didn't have diarrhea in the first place. And some of them went on to ischemic colitis and deaths from a condition that's normally non-fatal because people didn't listen carefully in the setting of a potentially powerful drug. And these patients did not have what the doctor labeled them as thinking they had. And that's a danger of mislabeling, substratifying patients with IBS, a common condition. It's also true that different words for the same condition change treatment that we need to be aware of. Numerous studies have been performed, and I've just given this one, which was a nice illustration of it in the British Medical Journal a few years ago, where they looked at the words that are used for common conditions, conditions that would not normally progress. And as the label was medicalized, the perception of severity on the part of the patient increased, and the preference for invasive management increased, and the patient's sense of control diminished. So the examples I'm referring to would be, for example, that case of hair thinning that I mentioned earlier. If you use the word alopecia, you're far more likely to move on to get a more invasive treatment, a more aggressive treatment, when in fact it's not alopecia at all. Another example that was used in this particular article was actually reflux dyspepsia. If one transmutes that into something like hiatal hernia, or use a very medicalized term, then one actually is more likely to get an invasive management. So the words we use do matter. They matter to the doctors and they matter to the patient. And if we move on to the area of medical science, which has consumed much of my time over my years, although I am a doctor first and a medical scientist second, and I use science as a way of thinking, but language influences our thinking, and language may corrupt our logic. We frame our thoughts using language, and that influences our judgment, our decisions, and our actions. And as George Orwell said, the slovenliness of our language makes it easier to have foolish thoughts. And I see that all the time with young trainees and older trainees and non-trainees and medical scientists. And I've been guilty of it myself. So as Mr. Humpty Dumpty says here, one should use words as you think they should mean, neither more nor less. But words change their context over time, and they change their meaning, and they need to be updated or dropped. And I've listed some of the things in my area of microbiome science that have led to profound misunderstanding. One being the hygiene hypothesis. That is actually almost correct, but wrong. In fact, hygiene is a good thing. It's not a bad thing. And yet good scientists have written books like Dirt Matters or We Need Dirt, which is not the case. The change in the microbiome over time has been a loss of microbes, missing microbes, not a failure to acquire microbes from dirt. And I've listed some other wrong terms that have created inappropriate conclusions. There's no such thing as good bacteria or bad bacteria. There's only context. And enterotypes is just a matter of gradients. But let me give you an example with probiotics. It amazes me how good clinicians depart from all their training and therapeutics when they come to talk about something like this. Consider this statement. Some microbes, including some lactobacilli and bifidobacteria, have beneficial effects on the host and are called probiotics. We studied some lactobacilli and bifidobacteria and found no beneficial effects on the microbiome. Conclusion, probiotics don't work. False conclusion. Some probiotics may work. It's a bit like saying, do you think tablets are any good or pills are any good? We'd never discuss medicine like that. It depends on the tablet, depends on the pill, depends on the indication. Likewise, probiotics are as varied as any chemical and as any drug. It makes nonsense to discuss them in the generic sense. And I've argued that the term probiotic should be retired. We need to be specific. A variant on this is some microbes, including some lactobacilli, have beneficial effects on the host and are called probiotics. We studied some lactobacilli and found theoretical bad effects, and the conclusion is probiotics have theoretical bad effects. Probiotics may have theoretical bad effects in certain contexts. Some probiotics are real and some are not. It depends on the particular bacterium, and what's needed here is specificity, precision, the very thing we aspire to, and yet our language becomes sloppy. This is an example of a bunch of lactobacilli and bifidobacteria that some people would call a probiotic, but there's only one probiotic here. In actual fact, it's the one in the center, which is the mouse, which has received Listeria tagged infection, and there's one organism that's causing the healing. Dysbiosis is another nonsense term because it implies bias. It is bias. It implies that a change in the microbiome is actually abnormal and needs treatment. In actual fact, the change might be appropriate. It might be secondary to the disease. And this could all be avoided if people just said what they mean. Why use a word, a highfalutin term like dysbiosis, when in actual fact, all you mean is a change, a difference? It's one step removed from the truth, and science is supposed to be about pursuit of truth. And the big area in my field of microbiome science, the one I specialize in, is actually antimicrobial resistance. Consider this bad use of words, in my view, bad messaging in public health. This is not wrong. Overuse of antibiotics leads to resistance and fewer treatment options for infections in the future. That's not wrong, but the narrative really needs to change. A much better narrative, in my view, would be to make it personal, because public health really only depends on individual behavior and influences personal health. So when one contextualizes, makes it personal, then you get a narrative like antibiotics also kill beneficial bacteria, which increases the risk of chronic diseases. Now, both of the statements are correct, but you need both statements. But the second one is the one that brings it tangible and real life and far more likely to cause behavior change. And furthermore, antibiotic resistance has a huge language problem. Public health officials have failed to actually get their points across because, in my view, they've been using the wrong language. And survey after survey shows that patients, a majority of patients, actually think that when we use the term antibiotic resistance, that it's the patient who's resistant, not the bug for which the antibiotic is being used. And these were surveys conducted by the CDC in the United States and also by the Wellcome Trust in the United Kingdom, finding the same results. So some of us are not getting the message across. There's even a greater error. I don't know if CPE or CREs are a problem in Canada at the moment, but they're certainly a huge problem in Europe. This is carbapenem resistant enterococci, and they've been declared as a public health emergency, but you'd never know it. This was before COVID crisis took the news headlines. In actual fact, this is actually an infectious disease. And if we use the term, if we explain to the public that antibiotic resistance is actually something that's contagious, then we'd have huge pressure on the construct of our hospitals, the design of crowded hospitals, and we wouldn't be treating it the same way in the lax way in which we do. If anything, CPE is likely to become an next stigma for the patient, so the patient will be blamed for something inflicted on them by the health service. And there are many other problems I don't have time to dwell on, but one would select out obesity, for example, in desperate need of better messaging, because what we've got really at the moment is making patients guilt-laden and our thinking on approach to public health messaging for obesity is siloed and incoherent, in my view, because of bad language. Now, the last part, I want to deal with the final topic, which is how to behave, what to say to the ill or not. And this was an entry in the diary by Alan Bennett, the great English playwright, who's written many plays, many of which have actually medical components to them, and I recommend them highly to you. But when Alan Bennett, who is a great fan of the NHS, the National Health Service, when he developed colon cancer, he became aware that the other people in the endoscopy unit knew that something bad had been found. And when he went out to make an appointment for the next visit and follow up and to pay his bill, the receptionist, who clearly knew that something bad had been found, suddenly became awkward and found it difficult to look at him. And he, in his turn, sensed this awkwardness and somehow felt ashamed and uses words like failure. And many people conceal a diagnosis of a serious illness when they're first informed, in anticipation of that awkwardness that people feel. They don't know what to say. It's that anticipatory stress or awkwardness that makes them conceal. Now, there are many other reasons why they conceal, but that's one of them. And I want to remind you of the testimony from doctors and nurses and other healthcare professionals when they actually receive an illness. There have been volumes of these now to supplement various illness memoirs. And one thing that emerges from all of them is that their memoir is really like an epiphany. They'll all say one thing. They hadn't realized the problem with language in medicine and the problem that people have, even trained doctors and nurses, how they find it so difficult to actually engage with the ill. And we of all professions, we should look after each other. Fred Weinstein, and I'm sure Dr. Sherbaniuk would agree with me, and Dr. Wensel would have agreed with me, doctors and nurses need to look after each other. This was a chilling account almost 40 years ago in the New England Journal of Medicine. And I read it every now and again, and it's no less chilling every time when I read it. This is a story written with that title, Isolation from My Fellow Physicians. David Rabin was a 45-year-old director of endocrinology in a famous American medical center. He was given a diagnosis of motor neuron disease. Now, he was still functioning as an endocrinologist. But what he noticed was that his colleagues that had previously been close collaborators, close colleagues, started to become awkward and avoided him. And previously sound relationships changed or waned. And family members will often report this as well. It's not just for the patient and the family, but the entire family. I noticed it myself when my son developed a very severe aggressive cancer. And it wasn't an uncaring nature in my friends. It was just they didn't know how to behave, in the sense that they didn't know what to say. And many of them would say, look, Fergus, I know you don't want to talk about this, when in actual fact, that's all I wanted to talk about. But they contrived reasons to not talk about it. And when you read this article, it becomes particularly chilling one day when Rabin fell. A longtime colleague was walking by. He turned. Our eyes met as I lay sprawled on the ground. He quickly averted his eyes, pretended not to see me, and continued walking. Now, there are many examples like that in the literature. They're not hard to find. So I want to just summarize many of these illness memoirs and make some points. I don't claim to be a total expert on this, but my credentials are on the basis that I played many roles in illness stories, and I've read hundreds of memoirs of what people say, and this is one of the consistent areas. What you should do, confront your own awkwardness. Always be there, give your time. And the ill don't need you to come in and chatter. Silent presence is frequently enough. Many patients will say all they wanted the visitor to do is come and just be with them, bear witness, and listen. And there's a short list of things not to do. Don't be a minimizer. Don't say, sure, it couldn't it have been worse? It might have been much worse if you lost the second leg instead of only one leg. No patient wants to hear someone downplay their illness. If it's a serious illness, it's a serious illness, and there is no point in minimizing it. Don't be a philosopher. No one wants to hear that it's God's will or the Lord works in strange ways. Don't be a philosopher. It's not your interpretation they're interested in. And don't be a peddler of remedies. If someone is unfortunate enough to develop alopecia areata, then they don't want you coming out with the latest thing from some quack down the street or Mrs. Murphy's remedy. Or if it is a serious cancer, be careful about introducing distractions with remedies and stories from someone else. And most particularly, one of the most consistent things that illness memoirs will tell us and that doctors need to recall, don't be a storyteller. Patients want you to listen to their story. They don't want to hear about John Joe Murphy from down the street who had something different but similar. That's of no value to the ill. Don't be a storyteller. So in conclusion, my time is just about up. Words matter. Words matter in the general world, but words particularly matter at a time when we've precious diminishing time for doctor-patient interaction. Don't make words be a barrier. Get rid of the 19th century legacy of silly words that we use and start using the illness words that patients need. I know people will say, but surely there are certain technical terms that we have to use. I'm aware that we need to use certain technical terms, but vastly less than what doctors think. The vast majority of those 10,000 words that I've reviewed that medical students learn in the first year are unnecessary. And bad language does become bad medicine, and I've given you some examples of that, and of course can corrupt logic. I haven't had time to elaborate on how it corrupts the logic of public health messaging, but you've seen many examples of that with the pandemic of COVID that we've been seeing. And finally, I ask you, get over your awkwardness and learn how to behave with the ill. The language for the illness is actually quite honest and quite simple. And if you don't know what to say, then the honest thing to say is, I don't know what to say. I want to finally thank you and salute these great Canadians. Thank you.
Thank you, Dr. Shanahan. That was amazing. It was very poignant and you know, really well put together. And I'm going to start the questioning, if that's okay. You know, as clinicians, first, we know that there is, and educators, there is this hidden curriculum within our medical schools, whether it's undergraduate or postgraduate, where, you know, we actually positively reinforce using medical jargon or medical language or what have you. How are you approaching at your institution, you know, some of the things that you've talked about today, and imparting that on your learners? And do you have any words of advice or words of wisdom with regards to how we should handle, you know, when we're on the wards with our learners?
Well, people would do well to go back to that video that I mentioned that you all produced, actually. And there's a delightful little clip in there that features Fred Weinstein explaining to the fellows, as he's posing questions, explaining to them how you might construct the questions. So my first answer is lead by example. I mean, most of what we learned, we saw good clinicians do it. And actually, Bob Bailey says that he developed his own style in time. But we learn style from seeing good people do it. And it is remarkable how few technical terms we actually need when you see people do it. Now, I don't like to make fun. In my book, I make fun of all these terms, but I don't like to make fun of students ever. And but I do point out that, you know, you might have as was in Margaret Edson's play, a professor of English, or you might have someone who's just also interested in words. And for example, I just point out when they're talking about the patient has a skin rash, and I find myself, I can't resist saying, well, where else do you expect a rash to occur? Do we need this tautology of skin rash? I mean, you know, all rashes occur in the skin. I like to point out, and I realize this is being mischievous, but when they speak of the past history, I like to ask them, you know, do you think the history might be in the past, and the past is history? So do we actually need all this tautology? And I definitely pick them up when they start talking about etiology, which is really the study of causes, not cause. What's wrong with a simple word like cause? You don't need etiology. And I of course, hate the term iatrogenic. That's clear obfuscation. So my best answer to you is learn from people who do it well. And we all have seen wonderful clinicians who do it well, and pick up on their style and acquire your style. One doesn't have to be an extrovert. Communication skills that we all teach, but I think they fall into the realm of common sense. And in our medical school, we're probably just the same as yours. We teach communication skills, but I really think a bit of kindness and common sense is all that's involved. I like to focus on the language and get rid of all these unnecessary terms and speak real. So that's my term for the students, speak real.
I like that, speak real. Sander, did you have any questions for Dr. Shanahan at all?
Fergus, wonderful, great. And just to the audience, I'm in his book. It's well worth it. Go for it. So Fergus, I have maybe two questions. So one is, I was taught by one of my attendings at the time that when you do rounds, the power of finding a chair and sitting next to the patient's bedside. That's my first question. And the second thing is, will better use of language help us overcome the problems we have convincing people that vaccinations overall benefit?
The bedside chair, I don't know what clinician said it to me, but someone said it to me as a medical student along the way. And maybe I've heard it many times, or maybe I dreamt it up, or maybe you told me, Sander. I'm not sure. But I do recall being told many times that one of the most powerful resources that one has is actually the bedside chair. And it's brought up by one of the illness memoirs, where a young doctor writing in the New England Journal, when he actually developed AIDS in the early days, he got a finger prick and died from HIV. But he made the point that when doctors felt that there was nothing more to be done, that's exactly the time when they could do the greatest amount, by just coming along and speaking with him and being present. That's what that bedside chair means. And Fred Weinstein actually used to have a favorite term. He used to say, when he'd refer to time, he'd refer to time in divided doses. It's remarkable. I know we all are pressured for time, but it's remarkable how we can improve our efficiency with time. And by that, he meant when you give a bad news to a patient on a ward round, say, sit down with them, tell them. It's remarkable how effective it is to come back a few hours later or before you go home that evening. Just look in on them and just say, look, I know I've given you some rough news today. Is there anything you'd like to ask me? That's extremely efficient use of time. So time and divided doses. Now, lastly, you asked me about vaccination. Look, I know as well as you do, and I'm sure it's the same in Canada, trying to convince anti-vaxxers with facts doesn't seem to work. It's like trying to persuade conspiracy theorists that they're wrong, or it's like trying to persuade people that, people who believe that Elvis Presley is still alive. You can't convince them that that's not the case. So I don't think facts seem to work. And getting into aggressive arguments with them doesn't work, but stories work better than facts. So there is evidence from the measles pandemics that explaining stories of children who were vulnerable and who developed measles and went on to get various encephalopathies from the measles, showing them what can happen, actually has an effect and will make caring parents who've been worried about vaccinating their children, possibly influenced by certain doctors that actually mispromote anti-vax campaigns. But if they're told stories and see real life stories of real life people with real life illnesses, that actually beats the facts and the logic. So I do think stories is the way to beat them. And I don't have a perfect solution for encouraging people to get vaccinated if, when we do hopefully get a vaccine for COVID. But I do think stories will be the only way we'll do it. And I think we've got to convince people that there's really no such thing as public health anymore. If there's anything that COVID did, it's shown us that we depend on the behavior of others, that our individual health is dependent on other people's health.
Thank you, Dr. Shanahan. There are a lot of queries about this talk and whether it will be available. Dr. Shanahan has given us permission to actually post it on the Department of Medicine website. I'm going to encourage every learner and all, including the R20s and the R21s, to actually have a look at the video. So once again, on behalf of the Department of Medicine, thank you so much, Dr. Shanahan, for taking the time, and congratulations on being the recipient of the lectureship.
Thank you.
So thank you, everybody. Have a good weekend.